Okay. Yeah. And you can see that this is an X-ray. This X-ray is an X-ray of how old is this patient?
Oh, this a child
Child.
because of the 5 years.
So after you heard that, so you see, don't you see how old is this patient? This is an X-ray of a child. You see, go on to say it. Don't wait, because I ain't gonna ask you why you say that. You see, the best students can predict. That's how you know you're comfortable. You can predict what the next question would be and be ready for it. In fact, that's how you should study. Be ready for the next question. Yeah. I mean, remember again, something that I think that students will appreciate is that nobody's at your level. Nobody's going to try to trick you. Yeah? Nobody's tricking anybody in exams, but obviously the post-grad situation, you have to show expertise. So they're going to ask you the weird question. Nobody's going to ask you the weird question to pass you in this exam. It's going to be very straightforward. So don't be confused. Right. So you can see this situation there again. I agree that that's a child, right?
Yeah.
Remember the principle I said again. Don't be saying, "Oh, this is 11-year-old or 12-year-old," because you don't know that. Nobody teach you yet how to do bone age. All you did say it's a child or it's an adult. That's all as much you can say at this level, right? But what you see here now, if you remember now, look and see now. Remember I said if you go up the neck, you should be able to pass through the lateral third of the head, right? You can see that you can do that here, right? Look here now. I'm going up here and I'm passing outside of the head. Agree? Equals this child has let me hear it.
Slip above the moral
There you go. You so straightforward that is. Yeah. There you go. So you know what you see. Remember the X-ray is going to be introduction, and then I ask you, well, tell me about that. Who gets it? You all should know how to talk about it. I know about the fat child and the slim child. Yeah. And blah blah blah. And what you do, you don't go reducing this. You pin it inside you. Remember that. You pin it inside you, and let what law remodels the bone? Wolff's law. Yeah. There you go.
You got to do that right now.
I hope so. Yeah. The other thing to remember that I know comes at the MCQ is that you remember what is acute and what is a chronic slip. Remember you say that? 3 weeks window? 3 weeks window. Yeah? Alright. You can see how that's a much severe slip, right? Agree?
Yes.
Look at the normal hip. When I go up the neck, I can pass through the head. I go up the neck. I'm outside of the head. The head is, you see that? So that's a severe slip. Well, this is the type of X-ray you'll get in the exam, right? One that is so clean and clear that you shouldn't miss it. And that's the pinning it there. And remember, I don't know the details about the pinning, but remember I said to you when I was showing you, you don't pin like how you would pin the regular hip and an on-slip hip, because remember the head. I have a, where is it? I have an example here of a slip to show you how you. Here, look at these two now. This is the normal hip. If I want to put a pin in the center of that head, I'm going to come in the center of the shaft here, right? To get into the center of the head. But because remember, because the head now is slipped, look at this now. You see how the head is slipped off the neck? So you see, if I go into the center of the neck, you see how it will come out of the head? So you can't do that. You have to then, look and see, as I say, you always have to come, look and see, you have to come anterior. Remember that's posterior now? You have to come anterior on the shaft to get into the center of the head. So normally the head is over here, so I can go in the center of the shaft and get into the center of the head. But because of the slippage, the head now is not there in the center anymore. So to get into, because the aim is to pin the center of the head, you can see to get in that center of the head, I have to come now anterior. You see that? So, I mean, that's a principle. That's an honors answer. Nobody can ask you, because they're going to ask about surgery unless you're doing very well. But the principle, you still have the whole way you get on the water to understand, well, why did you put that pin over there? Yeah, so whereas the regular fixation of a fractured hip in an adult, you will see we align it anteriorly because you're going into the center of the head. The child will slip, the head is out of place, so you want to pin it, you have to come in the front. Yeah? So go biomechanics. All right. Let's show you pinning again. All right. see this? Anything there? By the bag. Yeah, you see anything there? What do you see? Describe it. Remember again, as I said, even if you don't know what it is, fine. That's you don't even know what it is, but just describe what you see.
So this is an
Distal metaphysis.
okay.
Again. You see it there? You see it's there? Always remember the X-ray is going to have a label on it for you. Just look for it. All right, so it's the distal metaphyseal left femur, right?
Mm-hmm.
Right, and you see a lesion that has what? Look and see, it has different compartments. All right, you see that? Agree? So it's multilocular. Remember I said, look at the cortex, nice and clean, right? Agree? So look at the size of that lesion. When you look back at your tumor lectures, when you see a lesion that is so large and you see the cortex still remains intact, equals what type of lesion? A benign lesion. Yeah, you see that? Because if that was cancer, if that was malignant, that would have ruptured through the bone already. Yeah. So again, you see, so that's the principle again. Look back. I mean, I don't know if you were here for the lecture, but the 2 or 3 slides I said, please note for the exam. One of the things I put on that slide is that same principle I just see you. So because if that was malignant, that would have ruptured through, because tumors, malignant tumors would what? Invade and destroy, right? A benign tumor just expands, you see, and getting larger. Yeah. So there you go. And I mean, you can see they don't have this nice clear margins on a tumor. It's invaded, so you're going to see if that's why you get the what do you call them? Codman triangle and spicules, you remember? Because it's invading all over the place. But how nice and clean that is. So that usually is a sign of a benign tumor. Bar is not going to tell you what it is, so you can confuse you. You see, when you get the exam, you're looking for the name of it. As I will tell you, the student will get honors on just describing it. Yeah, you're looking and you're going to say what it is, and then the doctor asks you, well, how you know that? Do you see? So stick with the basics, guys. Let's describe it. All you're going to remember again, when that person comes to you in the clinic, you really don't know what it is anyhow, but you can predict what it's likely to be. So that's what the examiner wants to hear from you. All right. So again, there's a lesion. Let's look for the side again. Left. Always in the exam, and you see when you're the exam, make sure you show the examiner to show that, because you remember this is what you're going to have to do when you get in the work. Look for the label, you see? Because remember again, in fact, there was a good case, I was in court, and people, I mean, this is an example, but if you don't, when you're operating on a limb, and that's why you will see again, probably you haven't seen it, but you will see the surgeon will go and mark the limb beforehand, because what can happen is the limb that you're supposed to operate on looks better than the limb that you ain't supposed to operate on. You see when you get into surgery, well, this is the bad leg, or that's the leg that all twists up, but you're supposed to operate on the other one. So guys, another basic principle, make sure you have your limbs labeled. So in the exam, when the examiner give you, always, you see, you tell them that you know, left, what's the side? You see, we know it's left. Always is. If it's in there, send it right back to X-ray, right? You see it's labeled left, right? So we know it's left upper limb. Okay, so that's the way you're looking at it. So there's a lesion. There's a lesion in where? No, remember this is an AP and there's a lateral now. Okay. Yeah. So that's the AP again. So look and see both of the X-rays on one limb. That's the lateral. That's the AP and that's the lateral. Agree? Right. So there's a lesion involving the distal seal tibia. Agree? And look and see, it's going right down to the joint margin, all the right down, and me down in the malleolus as well too, medial malleolus. Agree? All right. It has this multilocular appearance. And guys, look at the principle I just said. What type of lesion is that?
Benign.
You see, you would agree with that, right? You see how massive that is? So right away it tells you, well, this looks so awful. What and you see how the inexperienced or the weak student will tell you that's a malignant tumor, yeah. But it's a benign tumor. Look at the cortex. There's no break in the cortex. There's nothing going into the soft tissue. Or again, I just said, benign tumors expand. Malignant tumors invade. Yeah. Look at the soft tissue. The soft tissue is just expanding, but it's not involved in it. Yeah. So let's go back now. My 3 slides that I told you in the tumor lecture. What you must know. I described this characteristic for you classically. The soap bubble appearance that goes right down to the joint line in the distal or proximal metaphysis, because you see metaphyseal equals. Let's see who read this off. There you go. Somebody got it. There you go. That's it. So that's exactly what it is. Yeah. So okay, guys. I mean, I know I taught you it. So yeah. So that equals giant cell tumor. Yeah, with that picture, you see that soap bubble right down to the joint line with no invasion in the joint. Look at the joint, it's still quite nice and clean. The soft tissues just expanded but not invading it. Right? Because remember, you have to differentiate it, as I said to you before, from the aneurysmal bone cyst that tends to look like that. But the aneurysmal bone cyst is away from the joint. Always remember that. That's the difference when you look at it in the x-rays. It will look like the same way. I mean, you see, remember, you're going to be picking these slides for the exam. They can show that one. Let's use that one. You see, or use that one, or they might use this one with the aneurysmal bone cyst to tell you which is which. You see, so that's the print. That's how you differentiate it. Remember, this morning I'm going through plenty of things, so you have to make sure you have a working knowledge of what you might be faced with. All right. Now look at that now. Look at that. Again, you see it's right. Now, look at this now again. Now, but you see there's a break in the cortex there. But look and see again this large lesion with no break in the cortex. All right. So there's a break in the cortex there. So what this patient had surgery. So what do you think was done? When a patient comes with a lesion, what we say, what's the definitive diagnosis? I said anytime you want to make it, you have to make it. There you go. So this patient had a biopsy of a benign lesion. Right? Yeah, so what it really is, you can see, look and see that the bone is, see how the bone is involved up here? So the history of this patient, what do you think this, so let's give you the history then of this patient. Let's see if you can make the diagnosis. This patient had a fracture when he was, an open fracture when he was 80 years old. He's 60 now. He's come back with this lesion. He has what? So he had an open fracture. There you go. There you go. So he remember. So he had an open fracture. So you see, remember as you get older, what happens to the immune system? Yeah. So it would. You see how he had walled that off for all those years, but all of a sudden now you see it flares back up now when his immune system is compromised. Yeah. So this is a patient who's come now with a late presenting osteomyelitis. So what do we call that? What do we call that again? A big hole in the bone. Let's see who remember the osteomyelitis now. A big hole in, what the holes in the bone are called again? So what are the features of osteomyelitis again?
Involucrum and suppression.
Involucrum is what?
I think that's a new bone forming.
New bone forming around the bone. And what's the hole in the bone? No, this question is the dead bone. The dead bone in the hole. The dead bone in the hole is the thing. The holes are called, and in animals we call them in the embryological open and I said, remember how to remember? A cloaca, cloacae. Alright, so that is, so again, look and see, so again, look at the whole bone, you can see that that's where the fracture was, right? And obviously the pus would have collected distally, the pus runs downhill, right? So it will collect distally. But you can see the old fracture there that has healed, and you can see it has remodeled, but not, you see it doesn't look like a straight bone, does it? Right? So you know that was where the old fracture was. Okay.